صباح الخير يا جماعة. It is I'm sorry for the delay for some technical problems, and it is our honor to introduce Professor George Tadros, Professor of Old Age Psychiatry and Liaison Psychiatry, Dementia in Aspen University, and he is also our visitor professor in this department. Professor Tadros, basically he is Egyptian British, and it is my pleasure to introduce him as he is the pioneer in new model of liaison psychiatry that is known as rapid assessment and interface discharge, which is established as an academic infrastructure and clinical pathways which are known implemented in 27 departments in the NHS in the UK. He established a new national network that has more than 600 members to spread good clinical practice in liaison psychiatry. His model has been now recommended for the Commission of Liaison Psychiatry and used as the benchmark of good practice by the Faculty of Liaison Psychiatry. He will talk to us today about the mental health in old age from wisdom to psychosis. So, Professor Tadros.
Thank you so much for the introduction. I'm really sorry for the delay. I thought we have to sort out the technology, but I'm really sorry. I will promise Dr. Mustafa I will finish half an hour. Is that right? Okay. So now I have more than one challenge. The first challenge was by Noha when we want to talk with you about psychosis in older people. And then Noha said, what if we start with wisdom? And I said, okay, let's do that. Maybe Zamalek was having a bad time and I wasn't concentrating very well, so I agreed. So now I have many challenges. One, finish on time. Second, keep you interested. Third, cover everything we want, talk about wisdom and psychosis as well. And more than that, I cheated a bit in the title. So Noha put the title like mental health in older people, sorry for the spelling mistake, and from wisdom to psychosis. I wish I had more time and we didn't have the delay, but because I want to have a debate with you, do we need old age psychiatrists? Do we really need them or not? And I hope we had a good debate, but at least I can instill the ideas in your mind. Let me talk about personality first. What happens? Older people are growing. I'm going to skip the numbers, but all of you know the population is growing. With Professor Shaheen with us in the room, in Egypt, the older population is also growing. The average age is increasing, the numbers is increasing. In the next few years, the older population will have many problems. And it is our responsibility, the university responsibility, to prepare people for this. What is aging? Is it old age or is it aging? I have Professor Suad Musa with us, and I'm going to say between Suad and our branch is strong link. It's aging, and aging begins from when we are born. And this is the idea. Very quickly, I lost the debate twice in England. I lost the debate twice. I tried to change the name of the Faculty of Old Age Psychiatry. I was the vice chair to the Faculty of Aging Psychiatry. We had a debate in the college and I lost it. Then they put a national debate and they chaired it and I lost it again. So that's not going anywhere. Primary aging, this is when the gray hair starts. In my case, that started early. Secondary aging is that when the body starts showing signs of aging, the bones, the metabolism, all these kind of things. I'll show you something very interesting now. Though it's a bit dark, if you try to circle your wrist with your thumb and your index finger, can you do that? If your two fingers can reach each other, you're possibly developing some osteoporosis and you're getting a little bit older. If you don't reach each other, you're young. Dr. Shaheen? Tertiary aging is when the brain starts tearing down. I'll skip through this very quickly because you know this. So chronological age is how many times the earth goes around the sun in how many years? All of us don't agree. Social aging. I'll do another exercise very quickly because of the time. With the person next to you, ask him or her how old you feel you are. And try to very quickly ask them how old you feel you are. Right? Most of us will feel much younger than our age. What is the threshold age? Age of retirement. In Egypt, I guess the age of retirement is 60. In the UK, it became 65, and then 67. And nowadays, I cannot retire. We open it up, as long as you can carry on. So how you measure aging? So in the UK, we have young old, that's a 65 to 75 roughly. Then we have old, and we have very old people. This lady, what do you think? How old is she? How old socially? How old is she? 20. You might think this is appropriate, you might think it's not appropriate. The same thing happening with old people. If somebody is looking after herself, people say she's a very lovely woman, she's smart. Somebody is saying, oh, she فاكرة نفسها نخرة وصغيرة وحاجات كده. But it depends. The culture has a lot of effect on that. Right. What happens to our cognition as we are aging? What happens to that?
Gets better.
Gets better. Very good. Thank you, sir. That gives us hope. Cognition gets affected. And I'm hoping in my original plan to ask how many geriatricians, how many neurologists in the room, gerontologists, all these kind of people can have a debate about it. But the point is, there are many factors makes us age. Guess one of them is what? You wouldn't believe this. Medication. People getting antihypertensive drugs, people getting sleeping tablets, even beta blockers, chemotherapy, statins. What does statin do to us? A lot of good work. What bad work it does? A lot of it. So this is what I'm trying to say. Okay, I'm not going to talk about this because I promised Professor Shaheen I will finish on time. You remember Erik Erikson? Just look at the last line. The last line in old age, you get integrity versus despair. Either you look back at your life and you say what? I had success, I had some failure, I had good things, I had bad things, but alhamdulillah, and I'm fine, I'm okay, I'm ready to move on. Or you look back and say what? Oh gosh, I made very big mistakes and no time to put them right, and we'll see what happens. And the context here, either you develop wisdom and perspective of life, you put it together, or you fall into the despair. If you put that into elder psychiatry, people, the original picture, the original idea is as we grow old, either you become sharper of yourself, your personality becomes sharper, you become harder person, or you become an easier person. That was all what we do. Now there's a lot of research for it. I guess 99% of people in this room are type A personality, right? This is why you're doing medicine and you're doing the university work and all these kind of things. The bad news for you is what? Type A personality will have big problem in old age. What am I going to do? What I'm competing with? What I'm going to achieve? My body is not responding to me. My brain is not holding it. Type B personality, more relaxed. But Peck took Erikson's ideas and we started developing them a little bit for the older people. So either ego differentiation versus work role occupations. If the way I know myself is I'm Professor so-and-so or I'm a Doctor so-and-so, guess what? When I grow older, what's going to happen to my titles? I retire. I'm not a doctor anymore. If all my life is just about being a doctor or being academic, one day I will lose that. What happens to my personality? Some of us try to develop other titles, like what? Like Hag, Mu'addis, Geddo, Ammo. But it's important as we develop to become ourselves, not our job or our title. Other thing, body transcendence or body preoccupation. When I want to be fit, healthy, I worry about everything. I have patients in England, especially female patients, who come and say, "Oh, look at my skin, it's crinkling now, and I don't like this, I don't like the way I look," and they get depressed. Or you become occupied with your ego, what I am, and I want to achieve lots of things. This is the conflicts you get in old age. Look at this man. Certainly old, but he's very, very preoccupied with what? Body image. Right. What happens in personality in old age? The Rochester trial is very nice, and they said there are 5 pathways. 5 ways when you grow older, you can go down them. Because I don't have much time, I was going to ask you which way you think you're going to go through. Just think about it. You have the chance to develop your personality. I have all my professors here in psychotherapy and integrated work that can tell you more about this. But I believe you still have a chance. 5 ways. One way is the authentic road. When you are content, you're happy with your life. I met so many lovely people who really, really impress you, despite of everything. But then you have the triumphant road. These are the old people who are prepared to face any troubles, resilient. If I get a stroke, okay, fine. I have some weakness, but guess what? I'll cope with it. I'll function. I'll still be independent. I'm developing diabetes. Okay, why do I do that? Take my oral hypoglycemic drug, I do this, I do exercise, I'm going to be resilient. But then you have people who are narrow in their thinking. Life must be like I say. And when they grow older, what happens with them? They become narrower and rigider in their way, and people avoid them. Then you have the Mandarin way, where you realize you have made so many wrong decisions. Somebody fell out with everybody, told them what they think of them, and then now he's very isolated, very unhappy, because of decisions they have made, and they're still not sure about their identity. The worst one is the downward slope, where you hate yourself, you hate people around you, you just, nothing is good in life, what is about life, and your personality becomes in this way. Richard et al. Took this theory and put it in, again, 5 ways. Said your personality in old age could be constructive, you help your family, you try to fit in the grandchildren, you talk about your experience with them, or you become dependent, the rocking chair. You have some satisfaction, but you want to sit and people bring you water and make the tea for you, the daughters make lunch every day, the granddaughter come and entertain you, and the whole world is just for you. Or you become defensive about what you have done and what you want to do. Or, guess what? And I'm not going to ask you to put your hand up, but put your hand up if you feel you can do that. Some older people become hostile, angry with everybody. Life did not turn up in the way they want, and they become angry. And the last one, they become even hate themselves. And you can see that in the society, you can see it in the films, everything. So intelligence, there are 2 types of intelligence. I'm coming to this for a reason. One type is the fluid intelligence, the wit. And that goes down with age, with the exception of Osama. I'm sure Osama will do very well. And you know why Osama will do very well? Because he does a lot of exercise. That's very important. But the other one is called crystallized intelligence, which is the layers on layers on layers of knowledge you have developed over the years. And that goes up. So you put the 2 together, we are more likely to maintain our intellect, our intelligence, for a very long time. Is that wisdom? What do you think? Is that wisdom? And I have disappointing news for Noha, because the research shows aging does not correlate with wisdom. For the young looking people in the room, there are more young people have more wisdom than older people. And there are older people have wisdom than younger people. It's not aging process. Wisdom is about being pragmatic in your answers. Put your ethical, moral integration together with your frontal lobe and make decisions. So that's just not for older people. So المثل المصري أكبر منك بيوم يعرف أكثر منك بسنة apparently is not true. Otherwise people will know more than us for millions of years. So there's no correlation in wisdom between the two. Right. So the best thing you do, I like this caricature, you plan for what? Plan to go up, grow on top of your career. If you're wise enough, plan for your retirement. That's what you need to do. So this is just under 15 minutes on personality, and I'm going to spend another 15, 16 minutes talking about psychosis. And as much as we can, please interact with me. I'd like to hear you. And Professor Shaheen will finish on time, I promise. Right. Look at this. This is a real story. And I dealt with this lady. So I'll call her Lizzie. People who come to England know Lizzie's the queen. That's the nickname for the queen. So Lizzie, we can mock our queen. That's not. I'm not going to prison for that or anything. So Lizzie is 76-year-old woman. She was a journalist. She's a famous journalist. She lives in Shrewsbury, which is a county outside Birmingham. And then she was seen by another driver driving her car high speed to Birmingham naked in her car. So the other driver just called the police. The police stopped her. And she said, what are you stopping me for? She said she's going to interview an MP, Member of Parliament, who died 20 years ago. But he was a famous Member of Parliament, was supposedly going to be the Prime Minister, but he had a sexual scandal with his secretary, and anyway, he died. She said he did not die, he's just in hiding. It's a big, he will come back to be the Prime Minister. And once she finished the interview with him, she's going to marry Richard Branson, and she will own the whole Virgin Airlines. What do you think? So they brought her to the end here. What do you think? What is she suffering from? Come on, guys. We have to accept Professor Shaheen's challenge. We should finish on time. What do you think? Bipolar. What else? Dementia. Good. What else? Late onset psychosis. Good. What else? I love that. Start systematically. So the first thing we start with is what? Delirium. How many geriatricians we have in the room? Put your hand up, please. So good few. So delirium. Right? I'm not going to teach you about delirium, but for people who don't know delirium, just remember, pinch me. Pinch me. Delirium caused by pain, by infection, dehydration, constipation, by medication. Alcohol medication causes delirium. And also hyponatremia, intravenous. Just remember this. Pinch me. And I'm going to teach you a couple of things only. One is the CAM. Has anybody used the CAM? Our geriatricians?
Yes.
Use the CAM?
Yes.
Other people know the CAM?
Yes.
Right. So this is the CAM scale. So sudden onset, inattention, or disorganized thinking, we diagnose delirium. That's the first step. But a couple of things. This is the vulnerability scale, from low to high. And I'll show you some political things in a second. And these are the insults, again, from low to high. From hyponatremia, dehydration, constipation to meningitis. And what happens with old people is this. If the vulnerability is low, you need a high insult. If the vulnerability is high, believe me, only constipation, only dehydration can cause delirium and all these kind of things. Do you remember Angela Merkel last summer when she was shivering in front of the camera? And what did the political media said? They said, oh, she has dehydration, and that's possibly delirium. Do you believe that? How Angela Merkel looks like? Vulnerable? Fragile? No. So it can't be dehydration, must be something else. Right. I'll show you this in a second. That's called the RAS scale. Anybody uses the RAS scale? Anybody, our geriatricians? When you see somebody with delirium, do you treat or you don't treat? Right? See, treat the cause. What about the psychiatric, the agitation? Do you treat it or not? You see this scale? There is minus and this plus. So 0 is just normal. Plus is agitation, aggression, violence. What about the minus? Withdrawn. Which hypodelirium? Which one is more dangerous? The hypodelirium or the hyperdelirium? The hypo one. This is mortality is high. But the point I'm trying to say is, unless the RASS score is between 3 and 4, you don't use any psychiatric medications. We only will reach the 3 to 4. Before that, please don't use it. Just very quickly to pass, because Professor Ahmad Latif was talking about sharing knowledge. How much benzodiazepine you give in delirium? None. Osama is saying none. This is absolutely true. We used to give delirium benzodiazepine in a small dose. From last year, following a review, we don't give benzodiazepines at all to any patients with delirium. Why is that? Increases mortality, increases falls, increases the length of the delirium. So we don't give benzodiazepines at all. We give haloperidol a little bit, risperidone tiny bit, and I'll show you how you use it. Right. So Lizzie did not have delirium, okay? What's next then? Everything was fine. She did not have delirium. No reasons to treat, nothing to treat. What is next? Is it drug induced? When you say drug induced in the elderly, what are you talking about? Cocaine and hashish and methadone? Do not talk about that at all. Alcohol could be? Hypnotics, benzodiazepines, anticonvulsants. I'm going to choke you. Beta blockers? I had patients with hallucinations because of beta blockers. Right? You have to think about these things. Right. This is what I really want to share with you. Any neurologist in the room? Right, so I can, Professor Magda's here. So in the UK, if somebody above the age of 45 coming with acute psychosis, well, I'll be absolutely negligent if I don't consider limbic encephalitis. And we have so many cases treated like schizophrenia or late onset schizophrenia, turns out to be limbic encephalitis. And limbic encephalitis is two kinds. One related to cancer, paraneoplastic syndrome. The other one is not related to it. And one is the voltage-gated potassium antibodies, and the other was an NMDA. I'm a psychiatrist. Do I look after patients with these conditions? I'm part of the team. I do that. So you have to think of voltage-gated potassium antibodies, NMDA antibodies. MRI scan can help you a lot, but about 20% of the MRI scans will come negative. About 20% of the CSF will come back negative. So we have to order antibodies. Antibodies takes about 6 weeks to come back, while the patient is hallucinating and aggressive. What do you do then? Give them antipsychotics? No. We didn't do that with seizures. Risk. Start with steroids. I had so many patients. Good dose of steroids, you control it, and patients start improving. Right. Could it be subclinical? Do you think Lizzie had subclinical seizures? Do you think Lizzie might have stroke? Yeah? Possible? Absolutely. Okay. All right. Lizzie did not have any reason to. Everything was fine. Everything was fine. Dr. Dalal said dementia. Right. So dementia, we know BPSD happens in dementia. What is the percentage of psychosis in Alzheimer's disease? Absolutely. So the mean of prevalence about 40%. People with Alzheimer's disease will develop psychosis. And the other study shows that level of psychosis increases every year. So it's a cumulative effect. Delusions, hallucinations, because of the benefit of the time, not cover this, but you can have this now. So what do you do then? What do you do? How do you treat? How effective antipsychotics are in psychosis and Alzheimer's disease? Actually, it's not effective at all. So a few studies, one of them had 420 patients, showed there is no evidence from placebo difference. The number need to treat can go up to 14. You have to give antipsychotics to 14 elderly patients with psychosis to make one patient better. Would you do that? You see the challenge? If you are going to give antipsychotics, just remember it can make the dementia worse and can cause falls, can cause strokes and heart attacks. Is it worth it? Depends on the balance between the cost and benefits. Right. Could be frontotemporal dementia. Okay, well, you know that better than me. It could be dementia-free body. You know the criteria, the 5 characteristics of dementia-free body. We give antipsychotics to patients with dementia-free body. If they are presenting, you never do it. You never do that. If they are presenting with psychosis, what's the best treatment? What's the best treatment for psychosis and dementia of the body? Acetylcholine resonators. Rivastigmine work really, really well. But what's the best antipsychotic you can give? It's clozapine. Who is prepared to prescribe clozapine to an elderly person? I'm not. Maybe I'll try aripiprazole or clozapine. Right. This is how you manage PTSD, which I'll skip because I'm going to talk to you something else. If you're using antipsychotics in dementia, please remember the 3 T's. And this is the guidelines at the moment. 3 T's. The first T is target. What I skipped with the last few slides, antipsychotics only work for people with aggression. So you have to have a specific target in your mind. The second T is titration. For older people, how much risperidone I give? Do you know? 0.5 milligram, maybe 0.5 milligram twice a day. Maybe in severe cases 1 milligram twice a day. I never give more than that. And the last T is what? Time. You don't exceed 6 weeks. Right, it is not dementia. So what is it now in the last 5 minutes? It's not dementia. Osama said late onset psychosis. Before we go to the late onset psychosis, it could be early schizophrenia and the person became old. How many of you seen older people with early onset schizophrenia? Numbers very small, very small. Because they die young, they have cognitive impairment, all these kind of things. The prevalence is about 0.6%. So that's not really our issue. What about late onset schizophrenia? Have you seen it? With the DSM-3, they said above the age of 45, DSM-5 opened it a little bit more, but 29% of people with schizophrenia develop it after the age of 44. 12% after the age of 64. Is it the same schizophrenia? Is it the same schizophrenia? We all deal with patients with schizophrenia. Is it the same schizophrenia? It isn't. It's different. You have less negative symptoms, you have cognitive impairment, but also even the delusions are different. It's not as sophisticated as the younger people delusions. Right, you get less of your hallucinations, more delusions. And just when say people can see me, how they can see me? They see me through the wall. It's not like they have cameras and computers and all these kind of things. Right. What are the theories? There are more in women than men. Maybe because women live longer. People have the progesterone theory, of the hearing problem theory. What about this one? So we talked about early onset schizophrenia, became old, late onset schizophrenia. What about this one? Very late onset schizophrenia. Have you met those patients? Develop schizophrenia very late in life. This is really, really interesting. And this is part of the new criteria: less negative symptoms, rapid cognitive decline, higher risk of tardive dyskinesia. The problem is there's no evidence that use of antipsychotics can happen. You have to be very careful. Right. So this is the management of it in the same kind of way. What about delusional disorders in later life? Do you see them? Do you treat them or not? That brings me to my last slide. Do you treat or not? Do you treat patients with late onset schizophrenia? Very late onset schizophrenia, delusional disorder. Depends on what. If I treat them with antipsychotics, I can give them heart attack, I can give them stroke, can make them fall, break the femur, I can give them dementia, Parkinson's disease. So would I treat or not? Depends on the risk. We are doctors, so we balance the risk against the benefit. I hope one day, if you see a patient, elderly patients with delusional disorder, that she thinks people across the road talk about her, but she's fine, functioning well. I hope when you see her, you tell her family what. Leave her alone. Leave her alone. If you're going to prescribe antipsychotics, small dose, gradual, ECG, watch for the symptoms. So you see, in old age psychiatry, we take things systematic, in a very logic way, in a very kind way. We are like child psychiatrists. We're very kind and we work in family atmosphere. That after you've heard my presentation, I'll ask you the same question again. Do we need old age psychiatrists? If old age psychiatrists are needed, I hope you agree with me, otherwise I'll be out of the job. Will old age psychiatrists work on their own? Will geriatricians work on their own? Will neurologists work on their own? Social workers? Old age psychiatry is about the integration between all these specialties focused around that one patient who needs our help. Thank you so much.
Thank you very much, Professor George, for this very interesting lecture, and it has pointed to how difficult is the practice of old age psychiatry. And it also pointed to the integrated work of all the psychiatrists and other specialists together in order to treat one old patient. So, we thank you very much for giving your experience as an old age psychiatrist in an advanced country, how do you deal with old age patients and how do you treat them, how do you follow the most recent guidelines in treating any patient. This is the way we should learn. This is the way I asked you this morning to share in the experiences of each other in order to get knowledge from each other. I was arranging to end the lecture with other scenario, but unfortunately we ran out of time, and that's why we will postpone it to another occasion. But I want to thank you, Dr. George, for being with us in many occasions, in many conferences, and for the cooperation with your place and our place. Thank you very much.
I would like also to say to George that I enjoyed your conference and your presentation. And I would like to suggest all of you to take the slides and read them for 3 or 4 hours, because his lecture could be for 3 or 4 hours, and have the opportunity, all of us, to ask him many questions about his practice in everyday clinical practice, in order to have his experience in everyday our clinical practice. Thank you very much, George.
Thank you very much, George, for this very enjoyable lecture, which is, it's like a journey, and it's stimulating our mind all the time. So thank you very much. And Dr. George is one of our team. He's not a visitor, so we are honored to have you all with us. Thank you very much.